Good morning, everyone. I'm Dr. Tara Kiran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine. Over to their incoming president, Mehlale Kumanen, to introduce the session. Mehlale.
Thank you, Tara. Good morning, everyone. My name is Mehlale Kumanen. I'm the president-elect of the Ontario College of Family Physicians. I'm really pleased to have you all here today, and I'd like to just take a moment to thank our panelists for being with us. Just a quick reminder that this session is MainPro accredited, and you will receive an email after the session outlining details of that. So moving on to our land acknowledgement, we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you're calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation.
Thanks, Mehlale. The land acknowledgement is an important time for us to reflect on injustices perpetrated towards Indigenous people, past and present, and how we can learn and unlearn and do better. And I'm delighted that today we have Amy Montour to help us on that journey. And one of the resources that she's highlighted that I didn't know about before were these series, webinar series from the Indigenous Cultural Safety Training Program. I did the training program a couple of years ago, and it was fantastic. I highly recommend it if you haven't done it. But these webinars seem like a wonderful adjunct and are also free and online. And this first one, I thought it was this wonderful diagram, and really also acknowledges the importance of us really acknowledging the role of racism in healthcare and our role in that as a starting point for movement moving forward. Next slide. As usual, our series build on each other, and you can access our past series on our webpage. The last series we had was on monkeypox and on COVID-19 with Dr. Alison McGeer. So there may be some items that we discussed then that we're not going to discuss again today. Next slide. So I'm delighted to introduce our panelists to you. As many of you may know, there is a nationwide problem with Rogers Internet and cellular, and that's really also affected some of our panelists. So just to appreciate your patience today as we're sorting things through. I think, for example, Dr. Fahad Razak right now is just trying to find some connectivity. But I'm going to start by connecting, by introducing the panelists one at a time, or let them introduce themselves one at a time. Next slide. So I'm going to turn it over to Dr. Montour to introduce herself first.
Sego, Ani, hello. Thank you for inviting me to be a panelist today. My name is Amy Montour. I am a Haudenosaunee woman from the Six Nations of the Grand River Territory. My background includes nursing and as well as a family physician. My practice is very varied. I do palliative care, I do adult inpatient medicine, and I've been fortunate to work with Brantford General Hospital in the last year, as well as some Indigenous colleagues, to build a division of Indigenous medicine within the hospital.
Thank you, Amy. So Fahad, I don't think is with us right now, so I'm just going to move to Jeff.
Thanks so much for having me. I am a pediatric infectious disease physician at McMaster University and McMaster Children's Hospital, and I'm also excited to be here as a member of the Ontario Immunization Advisory Committee. Dr. Kiran has suggested that some of you may not know that the committee was established last year by Public Health Ontario at the behest of the CMOH, and our job is to provide evidence-based advice to Public Health Ontario on vaccines and immunization matters, including program implementation, priority populations, clinical guidance, and vaccine safety. Thanks so much.
Thanks, Jeff. David.
Hi, I'm David Kaplan. I'm a family doctor and the Vice President of Quality at Ontario Health. I receive salary support from Ontario Health and a stipend from the OCFP. I'm glad I have Bell both at home, so I stayed at home and didn't go to the office where we have Rogers and no internet. So.
Thanks, David. Mahale.
Hi there, everyone. My name is Mahale Kuminen. I'm a family physician practicing in Cambridge. I do sit on the Echo Chronic Pain and Rheumatology Advisory Board, and I have received a stipend for some virtual care and COVID work at the OCFP.
Thanks, Mahale. So I introduced myself, Tara Kiran, and I've listed here salary support and research grants I've received, as well as some honorariums. And I don't think any of them pose a conflict for today's talk. Next slide. So today we're going to be starting off by hearing from Amy Montour about thinking about COVID recovery and how we can have a more equitable COVID recovery, one that addresses issues important to Indigenous people and improves their health. We're then going to, if Dr. Razak is able to connect, we're going to have him join at that point to give us a look back at where we've come over the last 2 years in terms of COVID in Canada, and where we need to go and likely will be going. And then we'll close out with Dr. Jeff Pernica, who's going to be talking about the COVID vaccine in kids under 5, which we know hasn't been approved yet here in Canada, but there is, information to share from the States and from what we know globally. So, and through all of this, of course, we're going to be answering your questions. So thank you for continuing to put them in the Q&A. Next slide. So just a reminder to put your questions in the Q&A box and just use the chat just to interact with. But if you can put your questions in the Q&A, that's great. I will be prioritizing for answering live. Next slide. So without further ado, I'm going to turn it over to Dr. Amy Montour to get us started.
Well, good morning. I've been asked to provide some context of what the COVID pandemic and the recovery has been for Indigenous people. To provide that context, we have to go back thousands of years, actually. As far as we understand it, my history, the Haudenosaunee have at least a history in what is called North America now, but what we would have called Turtle Island, dating back to the 11th century. That's sort of the beginning of our confederacy. So we've been in this land for a long, long time. And when contact happened, it also brought a wave of infectious disease with it. So we're talking about the 1500s here. And there were many diseases that Indigenous people in this country had never been exposed to. For instance, smallpox, tuberculosis. So this isn't our first brush with an infectious disease that is dangerous, that we've never encountered before. And even though in time, in mainstream time, that seems like hundreds of years ago or thousands of years ago, for us who are oral history people, those stories continue to be carried down. For instance, when the smallpox was ravaging North America, there were instances where armies gave blankets infected with smallpox to Indigenous populations. This was a purposeful, intentional move to eradicate the Indigenous population. Even though those things happened several hundred years ago, those stories are still told to us. I knew that story from my community at 8 years old, but I couldn't find it in the history books. So we have had many brushes, and we have had our populations decimated by infectious disease in the past. And these are stories that continue in our oral history. So on one hand, we have this relationship or this long-standing experience with infectious disease. But of course, just like everybody else in this country, when you're hit with something new like COVID-19, there's even more fear. And then we had the lockdowns, and we had limited access to healthcare. And what this really did for a lot of Indigenous communities is really magnify longstanding systemic racism in the healthcare system and the structural barriers that we face every single day. All of us on this call have heard the story of Joyce Echaquan and what happened to her in that Quebec hospital. But what we don't hear is the stories that happen every single day in healthcare across this country. Indigenous people hear them. We see our news stories, but those are not always in the mainstream. So Joyce Echaquan's case really brought it to the mainstream and said, what is happening here? It magnified it, but it also shone a light on it for our non-Indigenous colleagues. I don't think that it would have been spotlighted so much, and there would have been so much talk about it had we all not been sort of confined due to the pandemic. We have a long history of mistrust between Indigenous people and non-Indigenous people and mainstream healthcare in this country. What most of you don't know is that there is a two-tiered system for Indigenous people. If you're a First Nations person living on reserve, you have a jurisdictional nightmare because some of your healthcare is delivered federally, some of it's delivered provincially, and really those two systems don't talk to each other well. So there are multiple gaps, multiple places where Indigenous people fall through the cracks because of jurisdictional issues. That was created by the Indian Act, which continues to govern the lives of Indigenous people, First Nations people in this country to this day. It governs everything about our lives. The Indian Act also created the reserve systems. And we know that with tuberculosis and smallpox, the reserve systems were a catalyst for disease spread. You put people into a small area with inadequate housing, inadequate nutrition, and you have a population that becomes ravaged by a disease. We also have a history of Indian hospitals in this country, and this was a whole separate system. And it wasn't meant to provide culturally appropriate care for Indigenous people. It was actually meant to segregate us from the mainstream population. Because even though tuberculosis wasn't in existence in North America prior to contact, it spread like wildfire due to the housing and social conditions that Indigenous people were later on, as these countries formed, were introduced to. But somehow tuberculosis became an Indigenous disease. And this is the creation of the Indian hospitals to segregate Indigenous people. And they didn't receive the best care there. Long after tuberculosis could be treated with medications, they were still doing lobectomies on young people, young Indigenous people with tuberculosis. So that lives in the back of our mind as well. We had a whole system of medicine in this country that worked for our people. With the introduction of the Indian Act, residential schools, Indian hospitals, that system of Indigenous medicine was basically taken away from us, as our culture was the idea was to assimilate us into mainstream population so that we would give up our ways of knowing and give up our ways of medicine. So we had always that tension between our medicine and mainstream medicine. And yeah, there's a long history in Canada and the United States of Indigenous people having bad experience with evidence-based medicine. And what I mean by that is in the 40s, 50s, even before that, research studies were conducted on our children in residential schools, on our people in Indian hospitals without consent. And they were just put into these research studies. And later on, we found out about it. And there was no discussion with us. And most of the research that is done doesn't come from our perspective. And if you actually look at a lot of the research that's out there, there's very little Indigenous populations within that research. So it's very hard for us to see how the evidence always applies to us as well. So that's the context that Indigenous people have been going through this pandemic. But that doesn't mean that we can't come together as Indigenous people and non-Indigenous people and forge a new path in healthcare. There's an approach by the Mi'kmaq that's called two-eyed seeing. Very simple concept. We take the best of what Indigenous ways of knowing in medicine are, the best of mainstream medicine, and we see through both eyes, because that is how you would provide culturally confident care to an Indigenous person. As an individual, as an organization, if you're looking to really build your knowledge around Indigenous people and provide services that you think are more streamlined, more culturally sensitive to Indigenous people, my suggestion is that you reach out to your local communities. There are so many different Indigenous populations in Canada and in Ontario. And we're not sort of a pan-Indigenous type of people. Every nation has its own flavor, its own sense of who they are. So wherever you are, whether you're in Ottawa, you can reach out to the local Inuit populations, to the Algonquin populations. If you're in Toronto, you're sitting on Anishinaabe land, so reach out to the local Anishinaabe populations, the urban populations, and certainly in this southwest Ontario, we have Anishinaabe and Haudenosaunee as well as Métis in this area. So find out who's in your local area, reach out, start learning, build relationships, and together we're all going to make a better healthcare system in Canada. Thank you.
Thank you so much, Amy, for that really important historical context that you laid out that helps us to understand where it is that we need to move forward. It's wonderful for us to continue to think about your remarks around evidence-based medicine as we continue this webinar and talk about the latest science, and also keep in mind two-eyed seeing. And I love your suggestion of us reaching out to our local populations. And I wonder, Kirsten, if you could put the slide around Indigenous resources that pulled together for us that we'll be sharing with you while we're getting Kirsten to pull them up. Amy, did you want to speak to any of these resources?
Yes, so these are just a selection of resources, but I would highlight First People, Second Class Treatment, which was a 2015 publication, but done by Janet Smiley. The situation has not changed much. CanMeds has recently come out with an Indigenous health supplement, so there are competencies from our own college about where we should be at. There are specific cultural safety guidelines put out by the Royal College to help through the COVID-19 pandemic. In Plain Sight is a report done in BC in 2020 about systemic racism in BC. There's a brand new resource from CAMH 2022 on how to do land acknowledgements for non-Indigenous people. The Maduki Mishkiki Sharing Medicine video series is targeted to Indigenous people to talk about things like vaccine hesitancy and should we be vaccinating our children and what kind of Indigenous medicine can we use for COVID-19. So I encourage you to reach out and check those resources out. And then of course the ICS webinars gives you a good view of what systemic racism and structural barriers really look at. And then there was a 2022 report done out of Wabano in Ottawa with Indigenous people telling their stories of the experiences that they're having in current day with racism in the healthcare system. So I encourage you to reach out and check those out on your own time.
Thanks so much, Amy. And I understand that I was cutting in and out, so I've taken off my headphones and hopefully this is better for folks. Definitely let me know in the chat if you can't hear me. And thank you again, Amy, for that terrific presentation, the historical context, and the reminder of what we can do to improve things ourselves. Next slide. We're now going to switch it over to Dr. Fahad Razak. I'm glad to have you join us, Fahad. I know we're all keen to hear from you, especially since it's all over the news that we are in a 7th wave, and I believe that's the case from the wastewater signals that we're seeing, and this is just the slide from the COVID-19 Ontario Science Table. So Fahad, just since you weren't able to join us right at the start of the webinar, maybe I can just turn it to you to introduce yourself. So Kirsten, we'll go to the next slide. So you can introduce yourself, speak to any conflicts, and then take it from there.
Okay, hi everyone. Apologies to be late. I was also subject to this Rogers outage, so I'm calling in from a different location. I'm a general internist at St. Michael's Hospital, associate professor now, actually, just updated at the University of Toronto. I'm a provincial lead under David Kaplan in Ontario Health and the director of the COVID-19 Science Advisory Table. And I have no conflict of interest to declare. Tara, do you want me to, if we could go back one slide, do you want me to give a little bit more of a description in this section of what we're seeing and why we've called it a 7th wave?
Yes, please.
Yeah. Okay. So this is a screen grab from the Science Table's dashboard, which is one of the widely used resources to look at the wastewater trends in the province. This is the signal for wastewater from across the province, updated to the last week. Over on the right, you can see a fairly steep rise in the signal, and the pace of rise now is sort of similar to what we saw in early spring during the initial part of the Omicron surge. So although initially there was a little bit of a blunted rise, we're seeing something a little bit faster now, which is concerning. The second fact around wastewater is that it's showing that rise now uniformly across the province. So as little as a week ago, not all regions were showing a rise in wastewater signal, but now that's occurring. So again, those two data points together suggest strongly we're into this wave. The other things we've looked at are things like the percent of tests that PCR tests that are still being done that come back positive, and we've risen above 10% for the first time since May. The number of people in hospital has gone up for 2 consecutive weeks, again, first time since May. And the vast majority of public health units are seeing exponential growth in cases, and that's the first time since May. So I think putting this all together, that steady decline we'd seen towards the end of May has now reversed itself, and we're seeing a rise. As all of you know, this is largely being driven by the BA.5 subvariant of Omicron. The critical properties of BA.5 that make it more worrisome and difficult to contain are its immune escape. So even if you've recently been infected, for example, someone like me who was infected during this Omicron wave just a couple of months ago, we are susceptible to be reinfected. And so many people who are now more complacent, thinking, I just went through an infection, I'm triple vaccinated, I won't get infected again, are being reinfected in this wave. And that's part of what's driving it. Right now, there's nothing to suggest that the disease is more severe. However, one of the worries we have is that even an equally severe version that's widely distributed, that affects many people, can actually result in many more people dying or getting very sick. A recent analysis by Sharmista Mishra, who's an ID professor at the University of Toronto, showed that more people died in Omicron than the 2 prior waves combined. More people over age 60 died during the Omicron wave than the prior 2 waves combined. It just reflects the fact that it was a widely distributed virus during that wave. So if there are susceptible people and many people get sick, even if you have something that's even less severe like Omicron was, in fact, more people could end up dying. So with BA.5, again, nothing to suggest it's more severe. The worry is if many, many people get infected. We're typically a few weeks behind comparable European countries, and based on their rise in this BA.5 wave, which is being seen kind of uniformly, our anticipation at this point is that we shouldn't see a large rise in hospitalizations like we saw during prior waves. But again, the goal is to prevent infections, worrying about things like long COVID, disruption of work and family life, and of course, our most vulnerable. So that would be my brief summary on the signal. Tara, is there anything you want me to add to that part before I get to the rest of the presentation?
No, I think you can continue, and we'll take some Q&A. I think that people did want to hear about what you just spoke about, Fahad, so thanks.
Okay. So for this next part of the presentation, I'm going to summarize a paper that we just published last week. That was the first large-scale analysis to look at how Canada did in the first 2 years of the pandemic compared to peer countries. We really wanted to get a sense of how we did relative to other countries, because as all of you know, the pandemic has been a uniformly difficult experience for everyone in every country. And so in some ways you're grading on a curve in this comparison. You're saying, okay, things were really difficult here. How did we do overall in terms of our population, our ability to protect Canadians, provide good treatment, get people vaccinated? How did we do compared to others? And that was the focus of this analysis. So the first section to describe is how Canada experienced the pandemic compared to peer nations. Obviously, the decision around what a peer nation is very contentious, and people will say, well, look at us versus the US, things are so much more restrictive here, why can't we be like the US? So that's picking a comparator which is very relaxed about its rules. Other people will say, look at us compared to New Zealand, they've had so few cases, why can't we be more like New Zealand? That's picking a country, obviously, that's done very well. In a large pool of countries like there are globally, you could pick one country or another country to either make Canada look good or it look bad in comparison. What we really wanted to do is pick a large number of comparator countries that are similar along important lines that would be critical to understanding the pandemic policy or the outcomes, and then to not cherry pick one or two countries within them. So the things that we said were probably important to choose a reasonable group of comparators is that they have similar economic and political models. A lot of pandemic control was around implementing restrictions on personal freedom, so political models are important. You can't compare us, for example, to an absolute monarchy in Saudi Arabia because the rules are different. Economic models because of the impact on business, and then healthcare system capacity because you want to know that you're dealing with roughly similar systems in terms of being able to roll out vaccination, deal with very sick patients being admitted to hospital. We also said the logistics matter, so hard to compare Canada against a very small population that's geographically constrained, like Iceland. Part of the challenge here is managing a lot of people over a large territory, getting medications out, getting vaccinations out, doing all of those things. So we looked for the largest group of comparator countries possible using those criteria. So economic systems, political systems, healthcare systems, population size. The largest grouping that we found that existed pre-pandemic was the G10 countries. So we don't know of a larger grouping of countries that provide all of those comparators. So the focus of our analysis is saying, okay, now we have criteria, let's compare Canada against the G10 and see how we did. Next slide. So I'll say just briefly that the G10 countries actually include 11 countries. So even though it's called the Group of 10, for weird arcane reasons in the 1960s, they called it the Group of 10. Another country was added. There's actually 11. So the 11 countries in the Group of 10 are France, Netherlands, Belgium, Switzerland, the United Kingdom, Sweden, United States, Italy, Germany, Canada, and Japan. Importantly, if you ask yourself internally in your mind, what is a comparable country to Canada? You're going to see a lot of countries that you think are comparable on this list. So the United Kingdom, the United States, major European countries like Germany, France, etc. You're not going to see New Zealand on this list, for example, but you're also not going to see some countries that had much worse outcomes like Croatia on this list. Okay, so 4 panels that I'm going to go through here. The top left, and apologies for how small the font is, but I'll take you through these panels. The top left is the number of cases per million people over the first 2 years of the pandemic. As you can see, there's a huge spread between countries. Canada was 82,000 cases per million. This is up to the start of the Omicron wave. We didn't analyze Omicron because obviously the Omicron wave is not over yet. Less than a quarter of what was seen, for example, in France. If you look at the number of people who are vaccinated in Canada, that's the top right panel. We had the highest 2-dose vaccination percentage in the entire G10 at just over 80%. If you look at the bottom left panel, that's the number of cases per million that died. Canada had the second lowest in the G10, 1/3 the rate of the United States at 900 cases per million versus 2,700 cases per million in the United States. And if you look at the bottom right panel, excess mortality is a really important measure because it doesn't just look at COVID mortality, it looks at all mortality that occurred in society. So for example, if overdose admissions or overdoses started to rise, leading to fatal overdoses at the same time that you had these public health restrictions, or you missed critical cancer surgeries that led to increased deaths, all of that is captured in excess mortality. So this is total number of deaths. Now, you can see in every country, excess mortality was positive except for Japan. And Canada was the second lowest, again, like other comparators against the rest of the G10, less than 20% the excess mortality that we saw in, for example, Italy or the United States. So huge differences. Now, you'll notice across this that Japan is very low on a lot of measures. Japan is a really interesting country for unexplained reasons, not related to public health measures, not related to vaccination percentage. It has lower rates. There's other theories around what happened with Japan. We'll go to the next slide. So let me describe a few more restrictions and for a few more parameters, and I'll get to the interpretation. So what about public health restrictions? So if you look at public health restrictions, we use something called the Oxford Stringency Index. The Stringency Index is a panel of 9 indicators that include things like closures of schools, closures of businesses, vaccine mandates, restrictions on public gatherings, restrictions on international travel, vaccination requirements for travel. So putting all of that together into one index. This has been widely used to understand the total impact, the total portfolio of approaches used to control the pandemic. And Canada is second highest behind Italy on these measures. What's really notable about Canada is that it maintained a relatively high but persistently strict level of control. And the way that you can see that on this graph is by looking at the width of the box for Canada, which is narrowest on the top left panel compared to any other country. So we went high and we held that high level over the pandemic. And I think I show that in the next graph as well. So this is a heat map, and this is the number of days spent at various levels of stringency over the course of the pandemic. So the x-axis here is time, starting in early 2020 all the way to late 2021. And you're seeing the degree of restrictions that were implemented. So very low restriction is green, middle is yellow, high levels of restrictions are red. What you can see for Canada is on the second highest overall, and what you can see for Canada is after it went into periods of high stringency, it remained red, orange, yellow for the remainder of the pandemic. So we never really pulled back. If you compare that to other countries, we're the only country that maintained at a persistently high level. Even Italy had periods where it started to pull back, but Canada remained at that high level. So the takeaway on our restrictions are some of the toughest public health measures of any G10 country, persistently held over the course of the pandemic, unlike other countries that really had these waves back and forth. So tight restrictions, pulling back, tight restrictions, pulling back. Next slide. One particular area that I just wanted to mention that's part of the stringency is school closures. We had the second highest levels of school closures of any G10 country, behind only the United States. So one of the principal ways we tried to control things here was closing schools and limiting access for students to schooling, and there's been a lot of discussion about whether that was the right or wrong policy. Economic impacts. So I'll take you through this very briefly. Obviously, a very tough time for Canadians and for our economy. Looking at the top panel of unemployment, we are actually now at pre-pandemic unemployment levels. So although we did have a big surge of unemployment early, we are back to pre-pandemic levels. The second panel is percent change in GDP. We did have a pretty significant contraction of our GDP relative to other countries. So one of the biggest contractions relative to other countries. Inflation, although inflation is extremely difficult here for Canadians, it's important to understand that it's a global phenomenon. So we're actually middle of the pack in terms of our inflation rate. And then finally, our debt spending during this time to help bolster the economy during the pandemic and bolster the healthcare system. We are among the highest in terms of debt spending during the pandemic. We are left at a total level of debt spending that's roughly middle of the pack for the G10. So overall interpretation of the economic outcomes is we were sort of middle of the pack to a little bit worse depending on the GDP contraction. Next slide. Okay, so in summary, Japan had much lower COVID-19 burden than any other country, but for unclear reasons, not because of vaccination or public health measures. A lot of theories around this. It could be some stable genetic differences in the Japanese population, better use of masks in public settings because of a long history of using masks. Could also be prior coronavirus infections that have left some level of immunity, but reasons really unclear. Among the remaining countries, Canada had the lowest burden overall. And those differences were very significant in some comparisons. the Canadian public experienced some of the strictest and most sustained public health restrictions, including school closures. And most countries are now at pre-pandemic economic levels, things like employment and things like unemployment rates. Inflation has risen across most countries, and we're middle of the pack. Canada did do a lot of debt spending. We are now middle of the pack in terms of debt to GDP. I'll just give you one summary statistic before I finish with where do we go from here. So an important summary statistic for the impact of the pandemic on Canadians relative to other countries. Over the first 2 years, if we had followed high infection rate countries, for example, France, we would have had 9 million more Canadians infected in the first 2 years. So a quarter of our population would have been the difference, would have been additionally infected in the first 2 years if we had followed the policy of a country like France. Think about the impact on personal illness, disruption of schooling, disruption of work, disruption of family life, if that many more infections occurred. The second stat is death rates. If we had similar death rates as countries that were high mortality like the United States, we'd have had 70,000 more deaths of Canadians in the first 2 years. 70,000 means probably most of us would personally know a family member, maybe an elderly grandparent, someone who's immunocompromised who would have died in the first 2 years in Canada, who's alive today because of how different our policies were and our outcomes. So big differences between countries. So to conclude, where do we go from here? We have some real uncertainties going forward. The first thing that I'll mention before I go to monitoring is that we have some signs that our vaccination success has really started to fall off. So for example, although we were the leads in terms of first and second dose vaccination percents, we are solidly middle of the pack for booster doses. So that ability to get vaccines into arms has not been as effective now as it was earlier in the pandemic. We are starting to pull back on critical monitoring policies, things like PCR testing that makes it harder to detect variants that are circulating. We've had some critical lags in data over the first 2 years of the pandemic, which I think are important to address. So both completeness of data, especially who is getting sick among our most vulnerable population, and a time lag on that data so that we can act on it to improve outreach of public health measures. And then, as I mentioned, our booster vaccination rate has dropped and is now middle of the pack for the G10. There's other public polling to suggest that public engagement has started to wane at this point of the pandemic. People are clearly frustrated, fatigued, they want to be over it. Part of the conversation, I think, going forward is acknowledging it's not over. As I showed you from the wastewater signal, we're at the start of another wave. So how do we re-engage our patients, the public, to start to deal with this next phase of the pandemic? We think part of it is celebrating the successes, so acknowledging that we did quite well compared to most countries through significant sacrifice of the Canadian public, adhering to those public health restrictions, getting vaccinated. So saying you did these things, here's what was achieved, and now using that as a launch point for going forward to say, and now we're entering a difficult fall, here's what we need to do. The public health measures, so as you saw, we implemented some of the toughest measures. We don't think it has to be as tough as it was over the first 2 years. A good example is schools. We closed down schools to significant impact on childhood education. Can we keep schools open by restricting viral spread through other measures like improved air filtration, ventilation, mask usage in school, improving vaccination rates among children? Really prioritizing next steps for our population. So to say, here's what you've done now, but going into the fall, here are the additional steps that were needed, and some transparency around that to say, we're giving you, for example, the best vaccine we have available, but as early as the fall, you may need to get vaccinated again. So we think part of the messaging challenge has been saying, get these 2 doses in and we're done. And then people get frustrated because they think we've done everything you asked us to do, but now you're asking us to get vaccinated again. We think we probably have to be a lot more transparent around the uncertainty around this is what we know now, but things may change very quickly. That's the end of the presentation. I'm happy to take any questions, Tara.
Thanks so much, Fahad. Of where we've been and also, what we need to be thinking about. And I am going to just go to some Q&A now because we do have a number of questions from our audience. So just to start, on that issue of vaccination that you just ended on, Meeta Vij asks, when will the new hybrid COVID vaccine be available?
Yeah, so we are hearing, I don't have any deep insider information on this, but we're hearing as early as September, maybe the availability of some of the bivalent vaccines. So the bivalent vaccines will have the original Wuhan strain, and they will have an additional component that is tuned to Omicron. Now, what is uncertain is whether Canada's principal supply will have a tuned version which is more towards BA1 or a tuned version which is more towards BA4, BA5. Obviously that matters because we've seen that these sublineages of Omicron behave quite differently. The second thing that's uncertain is the volume. So if we get more of the BA1 tune, there seems to be more available globally of the BA1 bivalent. If we get more of the B5 bivalent, there seems to be less available, and then there will have to be some more difficult triaging decisions around highest risk groups that would most benefit from the BA5 tuned version. So some uncertainties heading to the fall. Our recommendation aligns with NACI, aligns with the Ontario government policy right now, which is we are at the start of a wave. There are, I think the last estimate I heard is 5 million people just in Ontario who have not received boosters to the full extent possible. That is principally third doses, and an important number of people who will also not receive their fourth dose who are eligible. Please help our patients get those. So huge opportunity right now to use the existing vaccines. And in the fall, we'll work out the eligibility for the new bivalents. For most people, they'll be 3 months out from when they received it and be eligible. For those who are not, we still think the protection available now from getting vaccinated for most people in the start of a wave outweighs the benefit of waiting.
All right, I'm going to try and get through about 4 more questions or so, Fahad. So, and if others wanted to chime in, please do so. So, Carol Timmons, on this point says, so do you recommend we get a 4th shot now, which is not designed for Omicron 5, or wait for the better designed vaccine coming in the fall, keeping in mind you need time between vaccines?
Yeah, so I would love other people's thoughts on this, and I'm sure Jeff has thoughts as well on this. I would say our best opinion is on average for a typical individual, obviously acknowledging that you have to look at individual risk and counseling and health history, that it makes sense to get the 4th dose now if you are eligible. So those are people over the age 60 and who are or otherwise high risk because they're immunocompromised or in certain designated categories. It makes sense to get it now. And that in the fall, newer vaccines that are available, they're sorting out the eligibility and the window, but the NACI guidelines say as little as 3 months. Right now, it's July, so it makes sense to get it, especially if the BA4, BA5 tuned versions are what we principally get. Those may not be as available as early as September. It may be even later into the fall. And I don't know if people who have line of sight like David on vaccines or Jeff have other thoughts.
And maybe I'll just ask one last question related to that, which is Terry Weinberg says, do we know when under 60 can get the 4th shots? And I don't know if you or someone else on the panel wants to answer that.
I'll just briefly say this has been covered a lot. I think Dr. Morris, Kiran Morris said yesterday that the government's actively considering it, and maybe in the next couple of weeks is what I read in news reports, just like everyone else. So without any deep insight on this, but looking to others on the panel.
Yeah, Jeff or David, you guys want to chime in on that vaccine 4th doses stuff? And then we're going to go to a couple other questions.
Yeah, I was just typing a response to Terry in the chat. Sorry. Yeah, I agree. Like I think Fahad's most important point is that we have like 5 million Ontarians. That's a huge amount of people that we need to vaccinate with 3rd doses and 4th doses if they already are eligible. And I think we've heard a number of times from so many people on this webinar in the last 6 months that this is a 3-dose vaccine. I think there was a study, Fahad, I can't remember who published it in the last couple of weeks, showing that so much of the death in people have been in under-vaccinated, meaning not boosted or never vaccinated. And I think we need to think about, how do we rally our efforts to get those people their 3rd dose, and focus our health human resources on it, because it's a big lift to vaccinate 4 to 5 million people in a short period of time. Like that's our entire our usual flu campaign.
Yeah. So, I think Nancy Leonard also chimes in here in the Q&A saying that the narrative to the public that fully vaccinated meant 2 doses contributed to the low rate of boosters. And is there a move to change the public message to 3+ being fully vaccinated? I'm not going to, so you guys are welcome to answer that if you know, but I think she makes a great point. And I'm going to move to a couple of other questions. A Song says, what data point would trigger return of mandatory masking given the evidence of a seventh wave with increased hospitalizations?
I'm happy to give you. So I think again, the decision on mask mandates is a policy question, because it includes things that are beyond science. It includes things like personal freedoms. Whenever you put a mask mandate in place, you're going to affect parts of the economy that have suffered the last couple of years as well. So my scientific perspective, which is only about the numbers of transmissions, is that there was an opportunity to keep mask mandates in place even as they were removed on critical areas of society where you don't have a choice. So you don't have a choice for many people of being on public transit. And if you need to get on public transit to get to work or get to school, and it's incredibly packed together and there's a lot of viral transmission, my belief is that mask mandates should have been in place and should remain in place for those kinds of settings. Same thing with hospitals where we have high-risk patients, that they should remain in place. So I don't think we have any single parameter to say mask mandates should come back into place. Now, what the public messaging from the Chief Medical Officer of Health has been on this is that he said as of yesterday that he is ready to reintroduce mask mandates, not only for COVID-related hospital burden, but also if we, for example, run into a fall season that has difficult issues with admissions around influenza or other respiratory viruses. So general viral transmission, respiratory virus capacity related demands, he's ready to put mask mandates in place. But I don't think anyone has a specific number on this.
Thanks,
Yeah,
Fahad.
it was really interesting that you brought up, Fahad, this idea of, there not just being a scientific lens to this. I was at a talk recently by Jason Leach, who's the National Clinical Director of NHS Scotland. And he really used an interesting framework. He talked about the COVID-19 health harm, but then he said that the Scottish government used sort of three other lenses. So social harm, economic harm, and then impact on health and social services. So there's like the two, we've really focused on the top two, which is like the COVID-19 harm and the capacity on hospitals. But, I think as politicians need to think this through, they do have to balance these other things like economic and social harm. And so it'll be interesting to see, what the government does here with, a broader lens, especially if we don't have the same pressure on the hospital system in the fall. I thought it was really interesting that Kiran said that.
We do have fewer hospital beds too than many of these other countries, so that also changes, I think, the dynamic. So one last question before we go to Jeff Pernica, and then this session, just a reminder, we'll go to 9:15. So between, after Jeff goes, we'll go back to the Q&A and try and get through some others, and also Fahad, hopefully while Jeff is speaking, you can type a few answers into the Q&A yourself. So I will, the last question is from Joanna Sachs, which is, how soon after initial COVID infection are you seeing reinfection?
I have some answers to that, but again, I would value other people's perspective. So the largest, so we obviously don't know in BA.5 because we don't have rigorous data yet. We're hearing people are saying they're being reinfected in as little as, they were infected a month and a half ago, they're getting reinfected. We're hearing that. In a large Veterans Affairs study, which is being extensively quoted around reinfection risk that was done prior to BA.5, the average duration of time between initial infection and second infection was on the range of 8 to 10 weeks in that large study. Now, this is on hundreds of thousands of people in the Veterans Affairs system. I don't know if any good evidence on BA.5, but again, looking to other people on the panel, if they have any data they know of. With COVID, I always say if I don't know it, it just means I haven't read it yet because someone published it.
No, I don't know. I don't have any better data than that either. Oh, did we just lose Tara?
I think we lost Tara, right? Can
wait,
anyone else hear us?
Okay. I can just kill some time before Tara gets back on. The one thing I was going to say, somebody asked, Fahad, I think you had excellent answers. I have very little to add. Somebody asked the $1 million question, I think, which is, is it better to get something now or to wait for a bivalent booster in August or September? I think Dr. Razak, you were saying, probably better to get it now. I think that's going to be the right answer for a lot of people. To be able to answer that question, properly, we would need to know sort of what's going to happen with this seventh wave and, what the effectiveness of the next bivalent booster are going to be, including, which bivalent booster we're going to get and when we get it. So I think it's going to be difficult to answer for some people. And so I think we will see some variability. Like I think there will be a lot of patients who want to get it now, and I think that's great. And there may be a few who want to wait, and I don't know that that's necessarily the wrong answer, just because there's so much uncertainty about exactly timelines for the approval of the boosters and what's going to happen with the seventh wave. Anyway, let's keep going, because I was supposed to talk about COVID-19 vaccination in young children. Next slide. I think a lot of people, a lot of clinicians, a lot of lay people are asking this question. Next slide. And really, the real impetus for vaccination of this age group is going to be to prevent severe disease in individual children. Because as we all know, the duration of protection against symptomatic infection or infection at all is going to be very short. Next slide. Now, when we look at the determinants of individual level benefit, obviously, this depends on how bad COVID-19 disease is in young children, how effective the vaccine is expected to be, and how likely it is that these children will develop adverse events following immunization. Next slide. So let's start with how bad disease is in these young kids. Next slide. I feel like in these discussions, the framing of my message is dependent on who I'm speaking with. Dr. Razak was talking about school closures, and certainly I would say, okay, that COVID-19 is not more severe than many respiratory viruses. I think it's less severe than a number, and so I think in Ontario, we had schools closed for longer than they needed to be. On the other hand, okay, you also have people talking about how COVID-19 is nothing in young children, and I do not think that that is accurate. So this study done in 14 states in America, just south of us, compared COVID-19 hospitalization in the first year and a bit of the pandemic to influenza hospitalizations in previous years for children, and really demonstrated that hospitalization rates were comparable to influenza, but this is in the context of extensive pandemic restrictions. So it may well be that there would have been more children admitted to hospital with COVID-19 had those not been in place. Next slide. Now, when we look at kids themselves, okay, what we can say is that certainly this youngest age group is hospitalized more than older kids. This is data from PHO's website, looking at the end of June, and obviously the 0 to 4 bar is a lot higher than the other bars. Next slide. I don't want to overstate the point. I think we all know that the strongest risk factor for the development of severe COVID-19 disease is going to be age. The rates in older adults dwarf that in kids. But still, it's important to keep in mind that this age group is at risk. Next slide. The relative heights of the bars are going to be influenced somewhat by immunization. And so they're a lot higher now in 0 to 4 than, say, the teenagers, probably because of immunization. If you look at Ontario cumulatively, the difference between the 0 to 4s and the 12 to 19s is not as stark. Next slide. This is not just seen in Ontario. This is data from the United States. The black lines are COVID-19 hospitalizations. The gray lines are flu hospitalizations in previous years. And what you can see here is that the black hospitalization line in the 0 to 4 year age group is higher than the teenagers. And immunization would have only occurred at the sort of the tail end of this curve. So really, okay, we know that this age group is at risk. Next slide. The differences were magnified during the Omicron wave earlier this year, where you can see that hospitalizations in the 0 to 4 year age group were much higher than those in other age categories. And this was the time when, as Dr. Razak already mentioned, hospitalizations were higher for children than at any other time during the COVID-19 pandemic. Next slide. This is despite the fact that we all know that Omicron at an individual level is less severe than Delta. You can see here it's less severe than Delta in children as well. It's just that there were so many additional kids infected. Next slide. Now let's talk a little bit about what the trials show. Caveat here, I am not on NACI, neither am I affiliated with Health Canada, and I'm only going to be talking, so what you're going to see here is freely available on the internet. This is not insider information, but I do not have the benefit of NACI's more intensive deliberations. I am only talking about Moderna because Moderna was submitted to Health Canada at the end of April. We should have a decision over the next few weeks. Pfizer has not even submitted yet, so that would not be around for months, if at all. If you look at the Moderna vaccine trials, this gives you an idea of the dosing of the vaccine in younger kids, as well as the size of the trial. So you can see 4,700 people got the vaccines in these two age groups. Next slide. And they were just randomized 3-to-1 to placebo. Next slide. Now, the trial results were positive, which led to the FDA approval, and the American Committee on Immunization Practices later recommended, based primarily on the fact that antibody levels in immunized children were comparable to those seen in young adults. Now, the efficacy against infection was not great, as many of you know, but these trials were very small, and so it is very possible that efficacy soon after vaccination will be better when more children are involved. There were no particular safety concerns identified in these trials, but remember, these are not large trials. Next slide. Oh my gosh, one thing I just realized, I should ask if people can hear me, because Dr. Kiran was mentioning that I was sort of quiet. Please, somebody let me know if I'm too quiet.
You're good now. You're good, Jeff.
Oh, perfect. In terms of other safety considerations, most people have been talking about cardiac APHEs, and I hope many of you have seen this publication by Dr. Sarah Wilson and Buchan that was published in May in JAMA Network Open, documenting the Ontario experience with myocarditis, laying out incidence rates for myocarditis or pericarditis in Ontario individuals by age and gender. So here's a good resource. If you have questions, if your patients have questions, next slide. Because of the way Ontario rolled out vaccine, they were also able to demonstrate that cardiac risks were less often seen with a prolonged intradose interval, which is good news for everybody. Next slide. Now, more good news, okay? We had always postulated that there would be less cardiac risk in younger children just because myocarditis in general happens less in younger children. In Denmark, they found 1 case in 200,000 vaccinated, and a recent publication documented that it was similarly quite rare in American younger children. Next slide. Ontario also put out this graphic in February, so it is not updated, but at that point, there had only been 1 case reported for the 1 million doses of pediatric COVID-19 vaccine. And Doctors Buchan and Wilson are working right now on updated Ontario-specific estimates of cardiac risk in adolescents and younger children. So next slide. At the end of the day, what I would say is that infants and toddlers are more at risk for severe COVID-19 than school-age children, or even adolescents now. That the 2-dose Moderna vaccine series is probably going to have comparable effectiveness in this age group. That I do not think that there is going to be significant excess cardiac toxicity in this age group, but really what we need to do is wait for the NACI submission, or the NACI statement, and the Health Canada opinion, which should be coming in the next few weeks.
Thanks so much, Jeff. And I apologize that I had some connectivity issues myself, so missed the first part of your talk, but I really appreciate these bottom lines, because I think, you know, what we need to do as family doctors is be able to counsel our patients about whether they should be getting this vaccine and supporting their kids to do it. I actually wonder, Kirsten, if you would mind going back to the slides, because we have a couple of slides there just to put a few things in context. There's been some polling done about parents' views, and and I think many parents are still hesitant to get the vaccine, and it's going to be up to us to kind of counsel them. So Kirsten, if you can put back the slides, we'll show those next few slides, and then I have a few questions for you, Jeff. So this is an interesting polling that I got from, I think there was a slide deck from Dan Warshevsky that he shared with me that I can share a few different slides around. So we can see that it is actually about half of parents, interestingly, said that they are interested in potentially getting their kid under 5 vaccinated, which is a similar percent who did say that for the 5 to 11. Now the uptake in the 5 to 11, I think at the end of the day for 2 doses is a lot less, and we'll see that in a minute. But importantly also, people who said they wanted to get their kid under 5 vaccinated, they indicated their preferred location is their child's family doctor or pediatrician's office. So, it does speak to the trust that they have in us, and that they want to get this vaccine, ideally from a doctor or nurse. Next slide. So what we can see here is just the uptake of the 5 to 11, as we've been talking about. And on the second, on the right here, we can see that 2-dose uptake is actually only at about 36%. So there is more room for us to do better even there, which kind of, I think, will kind of speak to the difficulty and challenges we'll have in the rollout as we move forward. And then we do have some, this next slide is just actually about the booster doses. So just driving home some of the points that we talked about earlier. So I'll end slides now, and we're going to go to a few questions, Jeff. So one of the questions is just about long COVID in kids and if the vaccination impacts this risk.
So I think we do not have good data to answer that question. I think the specifics around the incidence of long COVID in kids and the prognosis for kids with long COVID is still not well defined. I mean, I think what we know from the literature to date is that if one is going to get long COVID, it may be better to do so as a child than as an adult, because it does seem to be, it seems to last less long and to have fewer troublesome symptoms. But again, these are very sort of vague findings so far, and so I can't really answer that with any certainty. I mean, the thing that I would say about long COVID is when the school discussions were being had, all right, I think there were a lot of people who thought that school closures were important to prevent the occurrence of long COVID in children. I think what we are now realizing is that COVID is going to be around for a very long time. And so trying to not get COVID over one's lifetime is going to be difficult. Like I think it's going to be hard to never catch COVID when you talk about its cumulative incidence. So I don't know that the specter of long COVID in children is sufficient to, drive pandemic restrictions for this particular age group.
Thanks, Jeff. So a couple of other questions for you. So one is, so you've talked about the risk of myocarditis and presented that data, and just wanted to clarify, so how does that risk change as people get recurrent mRNA vaccines, so more than one? And do we know about that?
So there were third dose myocarditis risk data available from Israel, 9 months ago, 6 to 9 months ago, right? Because they were sort of ahead of the curve. It seems from the data that we have that cardiac toxicity post third dose is probably less than post second dose. There is data from the United States as well, and I'm sure Drs. Bucket and Wilson are going to be coming out with Ontario-specific data for that too. I think spacing is going to be important as well, as they aptly demonstrated in their most recent publication. So I do not think that we will get incremental increases in the risk of myocarditis post second dose.
Great. And then there's a question about the second dose for kids over 5. So if they have had COVID already, when should they be getting that second dose for the kids 5 to 11?
I mean, I would say, like, I have been sort of parroting the party line on this. Like, I think 8 weeks post-infection is a reasonable time to do that. Previously, it's because we said that we thought that the likelihood of developing COVID within 8 weeks of a previous was going to be very low anyway. That very well may be changing, right? But I think from a vaccine effectiveness point of view, that would also be important. I mean, it's good that the extended interval, this 8-week interval, is associated with less cardiac AFEs, but what we have known for even longer, right, is that the immune response seems better. It always seemed better with this sort of extended interval in comparison to the manufacturer 3 weeks. Like Marina Salvadori was talking about this a year ago. And so I think there are good reasons to try and aim for that dose 2 months or so after infection.
Thanks, Jeff. So we're going to go to some questions that aren't related to, that are just more broad than the pediatric vaccine. And again, Jeff or others, feel free to chime in here. I also want to just apologize that I've had some connectivity issues. So I want to thank Mehle for just summarizing some of the top questions because I can't see all of them now. But there was a question about the use of rapid antigen tests. And I wonder, Fahad, this might be a good one for you, Fahad. So there's a question about just the use of rapid antigen tests. What are the recommendations for using them kind of this summer before going to a wedding or a conference or other kind of gathering? Is it still useful to use them that way or not?
Yeah, my personal feeling on that is that it's still useful. It's imperfect. We all have to acknowledge that it's imperfect, but it is useful as an additional risk reduction strategy. So these tests probably don't work as well in highly immunized or people with high levels of immunity at baseline because of the way that it affects shedding of the virus. And so we think that it has value if it's positive. If it's negative, you still have to use other strategies. So infectious disease screening for any symptoms that were compatible, especially if you've had a recent exposure, would be important to consider even if your rapid test is negative. 2 consecutive rapid tests separated by 24 to 48 hours gives you an additional help if you have that ability to screen. So leading into an event, something a day or 2 before plus the day of together is more informative than just something the day of. But they're imperfect tests and have to be taken in context of your exposure risk and symptoms that you may have at the time that you're considering an event. And again, would look to other members of the panel to see if they have other thoughts on this.
I'm going to just move to a question about nitric oxide nasal spray. So Julie McIntyre says, can you provide any information about the status of the nitric oxide nasal spray Sanitize in North America or Enovid in Israel that was developed in part by the 2 Canadian researchers? It's been used in India. If effective, could it be beneficial for us? So I wonder if Fahad, you're able to comment on that.
I've only heard about these in a non-professional role from a colleague who was involved and said that there's pretty good data around these, but I don't know of the broader study base around these and would look to see if anyone else knows. So the idea is that they have this neutralizing effect. You use them 2 to 3 times per day, I think. And apparently the preliminary studies are very positive, but I don't know if anyone else does. insight on these?
So in terms of some other questions, so maybe Jeff, I'm going to go back to the you were talking, and just I think I'm just going to pick up on Rebecca Warmington's question. She wrote, and I think you answered it in the Q&A, but I think it's worth just speaking to, because she wrote that I feel confused by the data. Is 30 to 50% efficacy in kids under 5 worth getting vaccinated? How should I counsel parents? So Jeff, what pretend we are a parent coming in and we're trying to figure out, should we vaccinate our kids? What would you say? How would you counsel your patients?
So before I answer your question, I think that what we are seeing with COVID-19 vaccines is different than other vaccines. Like, I think people are very polarized. Like, I think there will be like a group of parents who are going to line up and get the vaccine for their children the first day it becomes available, and that is easy. And there are some parents who will not get the vaccine for their kids if you sent yourself and me and Dr. Razak to their house to have dinner with them and just talk about COVID-19 vaccines. Like, nothing would make a difference. I think for the group in the middle, what I would say is that it seems as though, and again, NACI has more information than me, so I am awaiting the NACI opinion, but it seems as though there is sufficient data to suggest that the vaccines will be as effective in this younger age group as they are in older children and young adults. The efficacy results from the trials are not great, but this is a very small number. So the confidence intervals around those point estimates are very wide. And that is efficacy against infection, which really nobody cares about much. We all know that none of the vaccines that we have are effective against infection for any age group, starting 6 weeks post vaccination, right? So we are no longer trying to use vaccines to stop the spread of disease. What we are most interested in is preventing severe disease and hospitalization in people. And I think there is a very good chance that the vaccines will do that in these children under the age of 5. Does that answer the question?
Yeah, I think so. I mean, I think we, as you said, Jeff, we're going to have more and more conversations about this, and we're, discussing it without the absence of the NACI recommendation. But I think that is really helpful. So lots of other questions here. I think maybe the ones that I'm going to prioritize just go back to this idea of the 4th and the 5th dose. So I think some people are just confused about like this recommendation to maybe get it now, and not knowing that, like, is there even a recommendation of what the interval would be for dose 5? And then I think Andrea Stern is asking, how much benefit is there for the well under 60 individuals for getting that 4th dose? And I wonder if you could speak to that, because if it is opened up, I think people are going to be asking us as family doctors whether they should get it if they are well and under 60. So what's the evidence around 4th doses for that group? And I wonder if Jeff and Fahad, you could speak to that.
So I agree with Fahad. Like, I think the province is thinking about this right now. I think we are going to hear something in the next couple of weeks about what to do with these age groups. I do not know that there are high quality data, all right, showing what benefit there is in terms of preventing severe disease in younger adults with a 4th dose, right? What I will say is that over the past year or so, it has been well documented that antibody levels wane with time post-vaccination, and you lose effectiveness not only against infection, but against severe disease in younger adults, whether that is, against Delta or against Omicron. And it seems likely that this is still the case, that somebody, age 35 who got a third dose, I don't know, in December will have less protection against hospitalization than a 35-year-old who got a fourth dose, even though we do not have robust data to show this, right? And so I think what we're going to realize is that it's not how many doses you have, it's the interval since the last dose. And the NACI statement that came out at the end of June basically said this, right? That clearly our job is to address the highest risk people first. They should be first in line to making sure their vaccines are up to date. But that even younger adults, if it has been more than 6 months since their last dose, may derive benefit. But I do not have reliable estimates of effectiveness against hospitalization in younger adult age groups. I think there's also one of the reasons that the OIC recommended opening up a third dose to everybody, even though NACI had not said that, is because there are also populations, racialized, marginalized groups who might benefit more from a booster than people who are not in those groups. And yet to target that group specifically with a recommendation sometimes carries stigma. And so it was suggested at the time that it might be more equitable to sort of open up to everybody, so no particular group felt singled out for that.
Thanks, Jeff. That's a really thoughtful and thorough response. I wonder, Fahad, if you have anything to add.
Jeff's response was just perfect. Very difficult area. We have the clear evidence in these groups NACI has identified for everyone else. You're doing your best to create some composite estimate, as Jeff said, based on risk and duration of time since they were last vaccinated, and it's very difficult. Hopefully we'll have some more guidance around it, because I think for all of you on the front lines, there's going to be a lot of questions in the coming weeks if the policy changes.
Great. So Kirsten, I wonder if you could put up the slides again. We're going to go, we wanted to let people know that there is, as we start to wrap up the session, that there's been a new CPSO guidance to the profession around the use of virtual care, and really stressing that, we're keeping in mind, so where clinically appropriate and available, that physicians must prioritize patient preference for in-person or virtual care. And that, it is basically not recommended anymore to have a virtual first approach. So we wanted to just flag this change in the CPSO virtual care policy and advice to the profession. Next slide. Also just wanted to remind folks that about some resources to support masking in your offices. So these will be in the slide deck, and we spoke to them last time. Next slide. And then last, I think we do want to go to a poll, because just as we end here, we know that there have been a lot of discussion in the news about emergency departments being overwhelmed. Some people in the news are saying that it's because they can't get in to see their family doctor. And I think we're just trying to figure out kind of the data and what's really going on, as opposed to the anecdote. And so we're going to launch a poll question. And I wonder, Mehle, if you could speak to this a little bit. So there's 2 poll questions here. And maybe while you're answering the poll questions, Mehle can speak a little bit. So the first question is, are you seeing patients with COVID symptoms in person? And if not, we want to know why not. And Mehle, I wonder if you wanted to give some further context.
Sure, thanks, Tara. So just to build on some of what you've said, I think it's really helpful for us to know what challenges and barriers you might be facing in primary care, and the OCFPs wanting to, as we plan for the fall, wanting to look to see how we can support you in ways that we are able to do so.
Great, so maybe Kirsten, once a number of people you can see how many people have completed the poll, and you can share screen, or we'll give you guys 30 seconds or so. There we go, thank you. So we see it's about 42% are seeing patients in person who have COVID symptoms. A lot of you guys are sending it to an assessment center instead. And a lot of you are facing barriers with the space. And then there's other reasons as well that we haven't captured here. And hopefully you can direct message us in the chat if that feels more comfortable, or send us an email afterwards as well to let us know. So I'll just go to the next slide. I do want to thank everyone who's made today and our COVID community of practice possible. So I want to start by thanking our panelists who took the time today to join. So Dr. Amy Montour, Fahad, Razak, and Jeff Pernica. I know today was a particularly trying day because of the internet and cell phone issues with Rogers. So thank you for making the extra effort and preparing for our summer session. I know all of us are grateful to have your wisdom. Thank you, David and Mehaleh, for being co-hosts and jumping in there where my connectivity issues failed. And then I want to give a special shout out to Kirsten Elridge, who hadn't done the kind of IT issues on our COP before and jumped in because our usual person wasn't able to log on to the internet. So Kirsten, you did a fantastic job. Thank you. Thank you to the rest of our team who makes this possible, and Mina Viscardi-Johnson and Adrian Spencer from the OCFP, Marissa Schwartz and Aaron Plenert, as well from the DFCM side, and of course Liz Maga and Kim Moran, who weren't able to be here today. We are going to take a little bit of a break for the summer, and our next community of practice will be on August 19th. We expect there will be some new kind of immunization announcements by the time we convene again, and so are anticipating talking about them at that time. And then we probably, again, won't have a COP again until mid-September after that. But as usual, we'll send out an evaluation. I would love to hear how you thought today's session was, and also what recommendations you have for future topics. And I know it was hard for probably many of you guys to join in today too. So thank you for making that effort, and take care.